Enterococci species, they are gram-positive cocci that grow in chains, and they are the commonly used, the commonly um, cocci that cause endocarditis and urinary tract infection. The pathogenicity is that they have antiphagocytic capsule and they produce enzymes that leave the host tissues, although they are relatively low virulence bacteria. So they are primarily due to the emergence of resistance in these pathogens are primarily due to the resistance to antibiotics, even though vancomycin, which is already a broad spectrum antibiotic, they still present with resistance. Next would be diphtheria. Diphtheria, the most commonly caused and the most common bacteriological agent is the Corynebacterium diphtheriae. They are gram-positive rod and they colonize the oropharynx. They present with clubbed ends in histology. And how are they transmitted? It's either through respiratory or through the skin. Exotoxin, the phage encoded AB. It is the A fragment that catalyzes the covalent transfer of ADP to EF2, which is needed for mRNA synthesis. So if this is blocked, there will be no production of mRNA. So that is how they block the protein synthesis. The tough pharyngeal membrane would present with pseudomembrane and toxin-mediated damage in the heart. These are serious or severe form of the Corynebacterium diphtheria. So they are passed on from person to person and may be carried asymptomatically. They can be present in the neglected wounds of combat troops in tropics. Note, inclusion of diphtheria toxoid in childhood vaccine does not prevent the colonization of C. diphtheriae. Rather, the vaccine is actually for the prevention of lethal effect of the toxin, like the toxin-mediated damage in the heart. Pathogenicity, they produce toxin, which is a phage-encoded, like an AB toxin, and then very characteristic would be the satellite lesions in the esophagus or lower airways. There will be release of exotoxin causing necrosis of the epithelium. And then there will be intense neutrophilic infiltration with marked vascular congestion, interstitial edema, and fibrin. And when the membrane sloughs off, like for example in the oropharynx, there will be bleeding or asphyxiation as it is thinned with diphtheria or Corynebacterium diphtheriae. Membrane is cuffed up and removed by enzymatic digestion. Again, remember, vaccination protects us from toxins, lethal effects of the toxins, but not from the bacteria itself. So pathogenesis, this is actually a diagram. A flowchart. Corynebacterium diphtheria infects the host, would release exotoxin, causing necrosis of epithelium and outpouring of a dense fibrinosuppurative exudate. There will be coagulation of exudate on ulcerated necrotic surface. There will be a tough, dirty gray to black superficial membrane. So other effects would include generalized hyperplasia of spleen and lymph nodes, fatty change in the myocardium with degeneration of myelin sheaths, and fatty change and focal necrosis of cells in liver, kidney, and adrenals. So this is a membrane of diphtheria lying with transverse bronchus. This is a pseudo membranous inflammation of the bronchus. This is diphtheric myocarditis with interstitial mononuclear inflammation. This is actually a manifestation of a chronic infection.